Hello, and welcome again to the Surgical Clinics podcast. Surgical Clinics is a bi-monthly publication consisting of review articles devoted to a central topic important to general surgeons. Surgical Clinics has published for over 100 years, and the series and the podcast can be found at www.surgical.theclinics.com. I'm John Vassallo, the managing editor of the series here at Elsevier, and for our fifth podcast, we will be discussing 4 articles in the February 2023 issue on management of breast cancer. Here to discuss de-escalating breast cancer therapy, genomic profiling, breast reconstruction, and quality of life issues will be our consulting editor of Surgical Clinics, Dr. Ron Martin, senior surgeon from the Department of General Surgery at Pullman Regional Hospital and Clinic Network in Pullman, Washington. Joining him will be the guest editors of the breast cancer issue, Dr. Anna Seidel, Director of Surgical Breast Services at Marshfield Medical Center, Marshfield, Wisconsin, and Dr. Lee Wilkie, Hendricks Chair in Breast Cancer Surgery Research and Professor in the Department of Surgery at the University of Wisconsin Carbone Cancer Center in Madison, Wisconsin. Welcome to all three of you, and over to you, Dr. Martin.
John, thanks very much for the introduction. Anna and Lee, thank you again for taking some time to meet with us and chat today, as well as all the effort that you and your colleagues put in on this issue. I know it's going to be very well received, and it's information that people really need. Obviously, there's a lot more than 4 articles in the issue, but we usually pick 4 per podcast so that we can have a bit of a discussion about it. And I'd like to start, Anna, with you, if we could start talking about the de-escalation issue. And just sort of by way of background, I'm going to need you to help me to understand some of the concept of it, because when I started out in this game now, pushing 4 decades ago, I was working with Blake Cady and Ricardo Rossi, and we were routinely being chastised for talking about how biological behavior was more important than anatomic distribution. And I think history's been a little bit kinder to our viewpoints, but de-escalation to me is kind of similar to the fact that we're just doing the right thing based on a better understanding of how tumors behave. But the big parts is, start with me just your general sense of what you mean by de-escalation, and then we'll get into a little bit of primary tumor stuff, nodal basins, RT, et cetera. So when you're discussing de-escalation, how do you describe that in the broad context?
Well, thanks for having us. Like you said, I think as surgeons, when I first started, I thought I cured cancer by myself. If I did a bigger operation, we didn't need anything else. But I think we're smarter in our understanding of our role. And when I first started dedicating my practice to breast surgery only 10 years ago, it was the big push to less is more. And the margin status was becoming clearer to us. We didn't have to have larger resections to get good cancer operation, good results. We no longer needed to remove axillary nodes in order to give us information on how to make decisions for additional management. Our adjuvant therapies were better. And I think we are proving that mentality that you mentioned at the beginning, that biology trumps surgical resection, and we don't have to do big operations to achieve cure.
Yeah, I mean, Blake, who is obviously a legend and my early mentor, his presidential address to the SSO back a long, long time ago was about biology was king, patient selection was queen, and all the operations and other tricks we had were the princes and princesses. And gender and monarchy hierarchy put aside, which probably haven't held up that well. But the general concept, if you think of it more in terms of chess pieces than gender assignments, I think Blake was on to something. And so one of the things maybe you can chat with us and the listeners about is we've kind of gone from the Halstedian concept of chop off a quarter of a human, then maybe gotten into the Fisher model. Now we're down to sort of no tumor on ink. So tell me a little bit more about how you want to rethink primary excision when necessary, kind of margins, what you need, what you don't need, re-excision philosophy.
Well, it's so hard because this has been my primary thought process now for these last at least 8 to 10 years, and needing to go back to where I was before with that paradigm shift. I think the article does touch very clearly on the no margin, no ink on tumor for invasive disease. and having the re-excision rates markedly decrease as a result of that information. I think our imaging has improved to allow us to be more directed. Our approach to non-palpable cancers has also helped us with smaller resections. I think it all is leading us towards that concept of de-escalating, less is more philosophy for curing cancer.
As I said, when I started this out, people had just barely abandoned the truly radical mastectomy, complete with pectoralis and everything else. And you got to be of a certain age to remember that. And it was largely gone, but there were still a few stalwarts that were hanging in there with it. Not many. But nowadays, I mean, I think we're sort of looking at, I mean, you know, bear in mind that in all fairness, Halsted couldn't spell DNA. I mean, it didn't exist in their world. And even when Fisher came around, we could spell it and we knew the sequences, but nobody could test for it in less than years of time. Now you can do testing fairly quickly. So we've entered a different level of thinking, which we're going to get into in the next discussion on genomic profiling, I hope, in some detail. I think these dovetail nicely in that way. But like, for example, lymph nodes. For those of us who were brought up in this big shift to it, where this is a systemic disease, the idea that you're going to go after this piecemeal is maybe not where it's at, and there were still people hanging on to that. We went from 3-level axillary lymph node dissections to, well, if 1 and 2 are good, or if 1 is good, then sentinel lymph nodes. I'm not sure we're even at a point where sentinel lymph nodes always hold up anymore. But so give us your thinking on, like, what do we do with the axilla, and either say the clinically negative axilla or the imaging negative axilla, or one that you got some real concerns about? How do you go about sussing that out?
Well, so the reason I was so passionate about this chapter is because I do have a firm belief that we as surgeons are going to be out of the axilla entirely. I remember vividly having discussions as an intern 30 years ago about whether or not axillary dissection and axillary surgery was diagnostic or therapeutic. And I think within our introduction, and Dr. Wilkie and I fortunately trained at the same time and have similar beliefs, I think, about this, we have come to where we've proven what we thought about axillary surgery is we no longer need to dissect the axilla. We've proven that a complete pathologic response with N1 disease, proving that their lymph node no longer harbors tumor, those patients can proceed with sentinel node only. And I think we're even going to prove, even following chemotherapy for lymph node positive disease, we still don't need to do an axillary dissection if they remain microscopic positive. And I think that's going to dovetail directly into the genomic profiling. Can we assess risk and make treatment decisions from biologic behavior, genomic profiling, and avoid axillary surgery entirely? De-escalate therapies.
And what do you think about the use of RT for radiation therapy for local regional control? Are we sort of in the same ballpark that systemic therapy, whether it's either cytotoxic, hormonal, or something else, is having an effect on how much we need to use in terms of local regional control with the various forms of RT?
For patients who are meeting indications for chemotherapy, can we de-escalate their surgical treatment and let radiotherapy treat their microscopic disease?
Or can we treat their systemic disease and not necessarily radiate everybody's chest wall and axilla? I mean, where's the balance and trade-off?
Exactly. And that's the question that is left to be remain, right? We don't want to de-escalate everything. And I think as surgeons taking the charge of de-escalating surgical interventions, at what point, though, are we going to de-escalate surgery, radiotherapy, all in the name of systemic treatment? And I think that's what you're asking.
Part of it is before the Halstedian era, we were undertreating breast cancer. People would take out a lump and people would die from progressive disease. Somewhere after that, we realized we were overtreating it for effect. Maybe not overtreating it in terms of it was still a systemic disease. And we've taken all these measures to say, do something for the patient rather than to the patient, which is not exactly synonymous. And then we worked our way down. And over time, we've got to doing more than X doesn't add more benefit. And I think we've held on to a lot of the things that we do because we always did them.
Right. And so what we're charged with is proving that Y is not inferior to X. That's where we are. And I think those of us in the industry, in this discipline of breast cancer surgical care, believe that we just have to prove it.
Well, I think that's the segue into at least the next part of the discussion I'd like to have with Dr. Lee Wilkie. In addition to the improvement of imaging, we also have an improvement of our ability to assess the actual nature of tumor cells on a genetic level. So, Lee, maybe you can walk us through a little bit about what do we mean by gene expression and profiling assays, and how do we sort of lead our way into this topic?
Well, thanks again to you, Ron, and the team and at Surgical Clinics for allowing us to really provide an update on breast cancer here. And we're very excited to talk through some of these issues with you. I'll dovetail a little bit on what Dr. Seidel said in terms of the surgeons are not going to be totally put out of business, because we still have some Halstedian-like cancers, those that just stay local, that just don't go anywhere, that the surgeon is still an integral part. But then there are also the Fisher cancers that are small and spread quickly. So that's where we're hoping some of these new quote unquote liquid biopsies will help us. As we step back, and I always like to thank the authors of these chapters because they really put in the extra time and effort, Dr. Marcinek and Dr. Murtaza, to help us understand these issues. But my favorite discussion with medical students and or residents is defining the difference between genomics and genetics. There is germline genetics, something someone is born with that's found in every one of their cells that defines their subsequent potential risk for getting a cancer. But then there's genomics, the mutations that are found inside the cancer. And that's the focus of the majority of what we're hoping to understand in the next 10 years. What are those mistakes inside the cancer that we can target, that the drugs can target, and then hopefully we can find in the blood to know whether our treatments are working or whether someone's developing a cancer.
I very much appreciate your description between genetics and genomics. As a recovering former geneticist in my undergraduate days myself, we didn't have nearly the tool set to do the cool stuff that people do now. We were interested in this concept of that genetic derangement would predict biological behavior, and that genetic derangement was non-uniform. So sort of towards the end of the chapter in this, we get into a little bit of the concept of sort of next-gen sequencing and stuff, and I don't want to really jump the gun too much, but we have heterogeneity among sample size, but we've also got polyclonal expansion. So not all tumor cells necessarily are going to represent all of the features of the other tumor cells. And I think our idea that one tumor cell is going to give us a totality of information about how the rest of tumor cells are going to behave is a bit of a to-do. So I don't know if you want to start in with discussing the next gen business now, or if you'd rather look at some of the commercially available profiling tools like Oncotype DX or MammaPrint or something like that. How do you work your way through that, the tools we have and what we're trying to figure out?
Well, I think we can dovetail a little bit on what you said in terms of heterogeneity. So we've learned a lot about heterogeneity, both through the commercially available genomic profiling tests, in addition to next-gen sequencing, which just does a much broader look at the mutations inside a cancer and helps us look deeper into that heterogeneity, but in a different way. So I think our genomic profiling tests, Oncotype, MammaPrint, PAM50, EndoPredict, each have a different number of genomic alterations they look at, whether it's 25, 70, 50, 11. They each have a different number of genes that they look at, and some have a greater number of clinical trials associated with them than others. But they have changed our approach and actually help us de-escalate, because these genomic profiles have really helped us de-escalate systemic therapy, highlighted the importance of endocrine therapy in our estrogen positive tumors, and allowed us to focus on the patient population that we all knew existed, the patient population that was node negative but systemically positive, and allowed us to focus on giving those patients the systemic therapy, which continues to change and evolve throughout the use of clinical trials. Oncotype is the one that is now incorporated in our AJCC staging. But I think over the next several years, we'll see others emerge with increasing evidence and data to support their use as genomic profiling tests. Next-gen sequencing is not as clinical trial tested, but has the great potential to teach us more about our cancers, understanding the different mutations and alterations that we should be targeting from a drug standpoint, but also giving us monitoring tools to know whether the cancer is evolving and changing. Because sometimes when you do an oncotype on 2 different tumors in a woman's breast, you may see the same profile. But I believe if you did the next-gen sequencing on those, you might see something different because you're looking at a broader array of mutations that might be within that cancer. And then we all know that when we test the metastatic site versus the primary site, we see discrete differences, that polyclonal population that then had the metastatic potential.
You know, I think in broad scopes, I see there's a tremendous utility in terms of risk stratification, but there's also a tremendous opportunity in terms of precision therapy, personalized therapy. And so I wonder if you could describe your thinking on some of these tools are good at telling us you're low risk, medium risk, high risk for developing a problem in the future. And other of these may be good at telling us this therapy or this combination of therapies may be better or worse suited for use. So how do you incorporate the data? How do you address that problem with people who come in?
You've clarified that really nicely in saying that our commercially available testing is really to help us risk stratify and determine, based on that risk, the escalation of therapy versus de-escalation of therapy. The next-gen sequencing is giving us an opportunity to look inside the cells and say, well, maybe we should be targeting a FRF2 mutation, which is not commonly seen in breast cancer, with a different FRF2 drug that we don't commonly use in breast cancer. We know we're starting to see our colleagues in esophageal cancer looking at the HER2 mutation and starting to use those monoclonal antibody approaches to the HER2 receptor to really target that type of esophageal cancer. So we're going to see that in breast as well. We're going to see that there are mutations that we wouldn't commonly think of in breast cancer, but we should be targeting. The androgen receptor, in our triple negative cancers, because we know triple negative is a broad array and heterogeneous population. And what drugs can we be using to target them, potentially in addition to our immunotherapy, which is just trying to help our immune system drive up and target these cells, but not necessarily those specific mutations. When
we go to some of the other stuff in this chapter on either circulating tumor cells or cell-free DNA, looking at either indications for or efficacy of what we're doing. So what are your thoughts there? Everybody is really hoping that the circulating tumor cell, or more often the cell-free DNA or cellular tumor DNA, will give us an ability to find cancers earlier. I think we need to refine the process first and really take it in its use to define response to therapy for existing cancer patients. Though I do think we're going to see, as we've seen in some of the studies with the cell-free DNA, the now commercially available tests, sometimes their sensitivity for some of the cancers is less than for others. But if we can take a patient's tumor, evaluate it, create a test for them, and watch whether that cancer comes back, I think that offers us a really great opportunity to be monitoring the blood in a patient that's already had treated cancer. So that's where some of these quote unquote liquid biopsies we hope will come into play. Part of it is probably an engineering biotech thing in that a lot of these circulating agents, you got to catch them at the right time. But I think there's reason to believe, and maybe I'm reading too much into it, but if the guys that are a lot smarter in this world at managing nanotechnology, they're going to find ways to screen things over longer periods of time. And I think that there's going to be a technological barrier to overcome that's going to make it easier to find things that are circulating and trap them and identify them before they're gone. But just like we've gone from amniocentesis to getting the child's DNA versus now getting it in the woman's blood, I always make the comment to my patients that, nowadays you can find a child's DNA in the mother's blood because it's 50% different than the mother. However, the cancer DNA may be 0.01% different in the patient with the cancer. And so it's really important for that technology to continue advancing so we can find that 0.01% different, which is what everybody's
working on, whether it's through methylation sequencing versus the apoptotic cellular debris. It's coming, and the technology will continue in that nano space to be able to find it. I used to predict it was 15 years down the road. I think I'm now down to about 10 years down the road, maybe 5. I keep lowering it because I keep hoping it's coming, because we'd love to monitor therapy. We'd love to tell the patient, gosh, we don't see it there. We think you're fine. Versus, oh gosh, we're seeing a blip. Let's look. Let's do our scans. We may not see anything, but let's think about where this could be happening and or hiding.
No, I think you're right. I think looking back over the time we've been at it, a lot of the big breaks have been predicted, but the time of when they would show up hasn't been. And then one day, like, something cracks and somebody figures out something in some lab somewhere else. I mean, PCR changed the world, and it just came along, not exactly in one day, but it came along pretty quick. And suddenly the world was divided into pre and post PCR.
Oh, I keep hoping, we all keep hoping for that aha moment of, oh yeah, you could see that methylation signature. We can easily find that. And wouldn't we all love to avoid mammograms and just be able to have our blood test? I don't know, which is worse, a poke or a mammogram. I don't know.
And it changed a little bit of topics. I mean, that's been fascinating stuff. You know, one of the chapters you picked I found was fascinating, this one on quality of life, because again, I keep referring to some of my early mentors, but one of the things they really tried to instill in me in my early days of messing with the pancreas after sleeping through those various lectures, was that you have to always make sure that you're doing something for somebody rather than to them. And you have to think about, it's not just what we want to do, but it's what they need and what's good for them. So quality of life has always been a topic that we struggled with a tiny bit in the pursuing of more surgical options, because I'm not sure whose interest we always had in mind. But these are important questions when people come into the office, because they might be interested in a lot of the scientific stuff we talk about, but what they really care about at the end of the day is, what does this mean to me? How does this affect me? How does this affect my family? I mean, there's a lot of topics in there, whether it's intimacy, anxiety, there's things in there, and changes in diet and exercise. But so maybe give us an altitudinal view about, what do you think the patients need to hear from us physicians about how this is going to impact them? And maybe what things do you think we don't do a very good job of discussing with them as much as perhaps we should?
Well, what I liked about the chapter and how it is set up is that the co-author is Dr. O'Riordan, who's a breast cancer surgeon and also a breast cancer survivor. And she offered a rather gripping point of view, quite detailed, but it was extremely eye-opening as to how we as surgeons may fall short in creating expectations, at the very least, for our patients and what to expect as a result of our treatments and recommendations. But areas where we can definitely improve, just bring up the discussion of sex and intimacy and side effects of medication. And I was impressed by the degree of impact upon the research for the chapter, financial concerns, self-esteem concerns in wearing T-shirts after mastectomy and with lymphedema. And I've been doing this caringly for a very long time. I think that I wanted to have this chapter in this forum to just raise awareness that it's something we should be talking with our patients about.
Are there specific, caveats, warnings, advice that you think that we should really be giving people that we're not? But do you think that there are some broad things that many of us are missing in terms of what we're telling people, or we just don't do a very good job of bringing it up at all?
Well, something that I've recently learned, especially even in our risk-reducing patient population with BRCA mutations, I focus on doing the right operation the right way and then get them in to see the OBGYN to get their ovaries removed. But we're putting these patients overnight, when we remove their ovaries, into menopause with all that comes with it. And I have not been expert in having that discussion with them about their hot flashes and their dryness and how that's going to impact their relationships. I think one of the messages of the chapters was have resources within your team and your program to be able to refer to at the very least. And I've gotten more comfortable with the discussions, and also we've gotten a more program for those referrals. But yeah, I think we're not asking the questions. I think that was the message. We're not, as surgeons, asking the questions.
I think that's an interesting thing, because in my very, very early days of the game, when I was at Lahey Clinic, we formed this thing called the Breast Cancer Treatment Center. And one of the novel things about it compared to where I'd been before was we had radiation oncologists, medical oncologists, plastic surgeons, us, but we also had the nurses and other support people for the breast cancer patients sitting in on these meetings. And in the process of that, one, we covered a lot more ground than I was used to, but we tended to get into our own lane a little bit. So it was like, well, you're going to talk about that with a support person who like helped them get different bras and prosthetics and support groups. But kind of as I've gotten older and been in charge of more things, it's like, you really shouldn't be part of a team if you don't know what your other team members are saying. So, I mean, I'm not sure where we are. I haven't been doing breast surgery for a long time, but where do you think we are in terms of group support and group understanding to make sure that the patient doesn't go home with a gap in their instruction or information base?
I think we're not as far along as we think we are. I think potentially we're checking the box as having the group discussion availability. But this chapter opened up my eyes as to some of the questions patients are asking themselves, going online seeking answers. And I have felt that I need to not rely on other members of the team so much to be the one providing some of those answers that were brought up of the questions in that chapter.
Now, do you think that that's a little more institution specific, or do you think that's across the board? Because, I mean, you and I obviously worked a couple of doors down from one another for a while. But I mean, I don't know what's going on in everybody else's center right now.
It is likely institutional. I can only speak for mine. I am hopeful that other programs are doing it better, but some of this patient perspective, I think, should be eye-opening for all of us. And I would welcome comments from Dr. Wilkie on this if you have any.
Well, I'll put on a little bit of my NAPBC hat, the National Accreditation Program for Breast Centers, that they've really shifted their standards and now calling it the patient journey, and have now focused less on how many sentinel nodes are you doing and removing to how often are you recommending exercise in your post-operative patient population. How often are you recommending referral to fertility and reproductive endocrinology in your younger patients? Not just focusing on, did you do the diagnostic imaging appropriately, but is the whole patient care coming into view? And did you discuss with the patient their values and concerns regarding their need for reconstruction or not? Did you offer no reconstruction? So I think we're starting to see, and especially at the national level, that change to the patient journey and how can we help with it. And I think we all know and understand that we need to be emphasizing nutrition and exercise in all of our cancer patients, and talking about sexual health and what that looks like. And we're very fortunate at UW to have a sexual health program, but sometimes I realize that not every program can have that. So it is important that we educate all of the providers around making sure that if the patient asks the question, we have a way of supporting it. And even if they don't ask the question, sometimes opening up at the end of a conversation and saying, what have I missed about you? What have we not discussed that you're worried about? So that we can ensure that that cancer journey meets their needs.
I think it's not a unique problem to breast cancer work, obviously. I mean, certainly, historically, the push has been find more patients who have a tumor that we can add more stuff to help them get better. In a crude sense, that's demand creation. Now, a lot of that was done for the right and noble reasons, and some of it was done for some maybe less noble reasons. But nonetheless, we've been trying as a big group in big surgery, if I think of my old big surgery hat, we've been trying to find ways to make surgery more relevant to more people to help them out with more things. Right up until the time they get an operation done and they were post-op. And then it's like, well, we kind of did our bit. Well, no, I mean, our bit goes on and on and on. And even though surgical relationships tend to be brief and intense, they probably in the grand scheme need to be part of a longer continuum. And I'm glad to hear that, at least on the breast side of the project, that's getting more say. I think we probably need that in the other groups, whether it's colorectal, pancreatic, biliary, esophageal. We all do things that alter people's lives, hopefully in some ways better, but often in some ways the downsides are not insignificant, even if it's worth the trade-off. We do need to focus on that. And I mean, to that thing, Anna, getting back to it, in the chapter, part of it we talked about was inducing menopause from reducing innate hormonal function. But we got a whole nother group of people that we give them hormonal therapy that has, if we look at the adjuvant therapies, maybe not the cytotoxic stuff at the moment, but the hormonal stuff and the radiation bits, to go back to our previous conversation, is, does everybody really need part of their upper torso and extremity radiated or not? I mean, where do you think we are with that?
I really think that we are going to prove that we don't have to radiate every patient if we preserve their breast, even if they don't tolerate their endocrine therapy. I think there are studies in place now. I had a resident who just got back from Miami and was discussing one of the studies for de-escalating radiation. And she was saying all comers, and I'm not aware of that. Maybe you can speak to it. Or, yeah, I don't think we need to radiate everybody.
Well, we certainly don't have to do anything to everybody. Some people even just say, I don't want treatment. And that's, I mean, it's rare, but sometimes it's okay too. I mean, and as we have a more and more aging population, and I think when you get to be at the point of the careers where we're at, you spend a lot of time focusing on dealing with your elderly parents and realizing that a lot of in the Gaussian distribution of patients that you encounter, we're going to have to really tailor what we do for people who are getting past a certain age, either chronologically or physiologically. There just is varying degrees of utility in your average 95 years old for certain things. But we've been focused so long on what can we do, we really haven't focused on how should we do it and should we do it at all. I mean, it's going to catch up with us because everybody wants us to figure this out, including us. In the chapter, in the quality of life chapter specifically, the amount of people that had post-mastectomy pain syndromes and other difficulty, I don't think that's fully appreciated by a lot of people. And maybe you guys can comment. Do you think it's fully appreciated by the people who are doing it for prophylactic means?
No, I don't. It hasn't been fully appreciated by me, and I've been doing this a long time. The reason I was passionate about this chapter is I have several patients with very early disease, DCIS, stage 1, young age, beautiful lumpectomies, straightforward radiation without complication. And they are in my office every year for follow-up, and they cannot handle their discomfort. They have nothing on exam, nothing on imaging, and they have severe breast pain that's affecting their quality of life. And I didn't find anything on that in the chapter, in the research, to be able to address it. But yes, I think we don't appreciate the potential chronic pain that we contribute to after mastectomy, lumpectomy, and radiation in the risk-reducing setting, in the cancer setting. And I think that this chapter was key in, like I said initially, just raising awareness, having us lay down the expectations for patients and have that discussion with them.
Well, I think that segues into the last chapter pretty conveniently, in that the best way to deal with chronic pain syndromes is to not create them, if possible. And Lee, the last chapter that you picked was really on reconstruction. And particularly, I mean, I don't think everybody's as savvy as you guys are about what do we mean when we say oncoplastic reconstruction. So maybe just walk me through your thoughts about how that differentiates from our usual understanding of things.
So not dissimilar from everything we do in medicine, we have to have fancy names for it. And so oncoplastic is just that intersection of ensuring that we're doing a proper oncology operation in association with some standard tenets associated with plastic surgery. So we know that blood supply is king, queen, prince, princess, however you want to define it. And whenever we do a lumpectomy, if it's going to be a larger tumor in a smaller breast or multiple sites of tumor, we'd love to rearrange that breast tissue to fill in the space because we know it's not going to regrow. And recognizing that our plastic surgeons have been doing breast reductions for years and filling in spaces for years on different pedicles and blood supplies. That oncoplastic approach is just recognizing and knowing the blood supply of the breast to rearrange and fill in the spaces that we've created by removing the breast tissue and trying to get symmetry. And a breast reduction is designed to do symmetrical approaches to creating a breast. So oncoplastic is that intersection of plastic surgery and oncology operations. And then we have all the other definitions that go with kind of breast reconstruction is skin-sparing mastectomy, nipple-sparing mastectomy, autologous reconstruction, implant-based reconstruction, and the evolution of plastic surgery and reconstruction has really been fun to watch. I certainly think that Dr. Seidel and I have watched the evolution from a latissimus flap, which really came around in the early 1900s, to the tram flap, kind of the crossover. I used to tell the patients that the belly fat from your left side was going to reconstruct your right breast. Because that vascular pedicle, again, it's all about the blood supply, was going to be the most important approach. And now we've got, the perforator flaps, whether it's coming from the belly, the inner thigh, the outer thigh, the butt, all of those, again, have fancy names, S-gap, I-gap, deep flap. But it's taking the fat off the blood supply and hooking it into a new blood supply and giving it a new look. But all of that has to be coupled with the expectations for the patient of what's the morbidity of doing these operations, what's the risk of chronic discomfort, what's realistically gonna look like. It is not gonna look like an implant-based augmentation. The breast is removed and we're trying to fill in the space with something, whether it's through oncoplastic approaches with breast conservation or reconstruction with a mastectomy.
Loss of skin sensation, loss of nipple sensation is a big to-do. And if we can avoid either of those, it's probably good. So work us through a little bit, like in your evaluation of a patient, how do you decide who you think is a good candidate for preservation of skin and or their nipple? And what do you need to know to make those decisions up front?
Well, I think as with everything, we've evolved. It used to be that we had a few rules of thumb for nipple and skin-sparing mastectomy, where you definitely wanted a certain distance from the nipple for the cancer to be. I think nowadays we are focused more on just negative margins, no tumor on ink. Certainly a patient with Paget's disease with DCIS in their nipple, I'm not going to preserve their nipple. But if I think I can get them no tumor on ink and a negative margin, I'm willing to do that mastectomy in a skin and or nipple sparing way. I think a lot of what Dr. Pellet and Dr. Clavin focus on in this chapter, which I think is important, is we used to also say that you had to have the perfect breast size to do that. And nowadays we have some techniques which have been around again for a long period of time. Again, it's all about blood supply. If the nipple and breast if the breast is very ptotic or very large, that blood supply is on stretch. But can we improve that blood supply by doing a delayed approach, cutting the skin, giving it some new neovascularization, and then maybe it'll live in a delayed fashion?
So that leads into exactly my very next question. So sequenced or staged procedures, to me, are always the most fascinating. You still have to live with wherever the patient came in with the tumor. That unfortunately sets the stage no matter. We always got to play the cards we're dealt. But what is the process for you and your colleagues looking at one of these things to decide how to sequence, stage your operations? Like run maybe through your workflow to decide how we're going to decide which operations to be done in which order and over what time frame.
No, I think it's a great question. It gets back to that thought process around personalized medicine and a precision approach, so to speak. If it's a cancer patient, you really look at the extent of disease, proximity to the nipple. Can we get negative margins using the radiological tools that we have, whether it's MRI, mammogram, or ultrasound? Then looking at breast size to tumor size ratio, also factoring in a neoadjuvant approach or not. Is this patient eligible for a neoadjuvant approach that can shrink the tumor so that then we have a better opportunity to do either breast conservation with an oncoplastic approach or a mastectomy with or without reconstruction? The idea of delays are an important one when you're trying to save the nipple. If you have a very large breast and or a very ptotic breast, a nipple delay is a good approach to try and get a better blood supply. For the oncoplastic approach, if at the first operation you're not certain you're going to get all the DCIS out, we'll do a delayed oncoplastic reduction, because then I wait for the margins, make sure they're negative, and then they go back and do the delayed reduction versus shifting everything around at that first operation. And I don't know where to go back and get that superior margin.
At the end of the day, there's always the issue of patient selection. And I mean, we frequently come up with clever things that we can and would do. What are your major inputs on the patient selection side that sway you one direction, another direction, avoid something altogether? Do you have any hard and fast concerns?
I think there's some concerns when you're talking about reconstruction. Certainly smoking puts us in a difficult situation if a patient is a smoker. A patient has uncontrolled diabetes. So you have to look at their comorbidities and their surrounding medical history to really understand what the risks are to the associated extent of the operations you're going to do. But beyond that, it's a discussion with a plastic surgeon and the patient around their expectations, values, what they want it to look like, what we can do, what we can provide as what it's going to look like. You briefly mentioned at the beginning this idea of maintaining sensation. I think we're on the edge of understanding how much of that we can do versus not. We all see the nerves as we do our mastectomies, but sometimes they dive right through the breast. And at other times, using a nerve graft is sometimes difficult or not possible. So again, it's personalizing the approach. Sometimes recognizing we may not be able to do that personalized approach till we actually get in there and understand the operation and what the blood supply is. But it's setting expectations ahead of time as to what's possible and what is on the cutting edge and what do we think we can do.
I had some flashbacks looking at some of the pictures because in one of the iterations of my earlier career, I spent a lot of time in Iraq and Afghanistan. We had a lot of people with big axillary injuries from IEDs and various things. So we did a lot of nerve grafting and cable grafting under sort of living in tents and stuff. But, you know, we did what we could and it worked out okay. But the idea of trying to preserve it, I mean, that was tough sledding for us to get. I mean, granted, these are usually brachial plexopathies. We're not, I mean, it's high price real estate. But you're still in the neighborhood of a bunch of nerves that are also predominantly sensory, let alone motor. I mean, that's challenging work. And I almost wonder how much it parallels what some of our ENT colleagues do trying for nerve presentation around particularly parotidectomies and the like. I mean, there are a set of skills as to how to work around delicate nerves and make matters work. Certainly when I grew up, the idea that you just took sensory nerves and that's just the way it went. That's the way we were trained. It wasn't particularly nice. We were supposed to avoid the ones that had motor function, but nobody really got wound up about some of the others. And I hope that's changed over time. And it seems like there's some good skill sets to do. But again, I don't know that the average person, and certainly I was not, but the average surgeon out there, general surgeon who doesn't specialize like you guys do, is aware of much of some of these sensory concerns after. And I think you're right. If they see nerve going into tumor or going into breast tissue, that just goes with it. Maybe that should have a lot more thought put into it.
As you've said, we moved from the axe dissection where we took every intercostobrachial nerve, and now we try not to, and just take the nodes and preserve both the sensory and the motor nerves. And we're learning how we might be able to do that for the breast, for the nipple itself. And you're right, learning from our colleagues is super important, whether it's our neurosurgeons who are fixing the brachial plexus or our ENT colleagues working on the parotid. As surgeons, we need to be open to thinking about the new ideas. I don't know if I'm walking into the robotic mastectomy yet, but we'll see what these younger colleagues who are used to playing video games can teach us.
Well, one thing that you can teach them is that you can still operate without videoscopic means. It is technically possible. And I would say that I get called in a lot more now to help somebody who needs to go away from videoscopes than I got called in earlier in my career for somebody who wanted to do something with a videoscope. So we do have a paradigm shift in big surgery that we need to pay attention to before all the people who remember how to operate open have retired. Yeah. Robots are great for computer-assisted videoscopic stuff. I'd have to leave it to you guys to tell me how they make some breast work better than what you can do without them.
we're looking forward to the clinical trial that's evaluating it. There's a team of people evaluating it. And I think we'll look forward to those outcomes, just like we used to look forward to the outcomes from all of the clinical trials that have shaped breast cancer.
Well, we will. So on that note, I will say one thing. Breast cancer, by far and away, is one of the best studied, from a scientific standpoint, diseases in the history of surgery. You know, big science. I mean, certainly cardiac bypass stuff, gastric acid secretion, and operating on ulcer disease. But breast surgery, in terms of actually doing trials, getting data, being serious about it, is pretty much unparalleled. And to those of you who continue the tradition, we owe you a huge debt of thanks. So thank you. Any comments from either you, Lee, or Anna, that we haven't covered on these things that you wish we had?
We appreciate the comprehensive review of these chapters and highlight that there are others. I appreciate the opportunity to focus on these.
Well, thanks so much for doing it. We really appreciate it. Anna, any thoughts as we close?
No, just that the 4 that we chose all, I think, speak towards quality of life: precision medicine with genomics, de-escalating therapy, nerve preservation, and the quality of life chapter.
I do appreciate you guys' time. I know you're busy and been traveling, and we know it's hard to get to it, but thanks so much for spending an hour or so with us doing this. Thanks.
Thank you for joining us for the Surgical Clinics podcast devoted to management of breast cancer. The 4 articles discussed, as well as 10 others, are in the February 2023 issue, Volume 103, Number 1. This series is available for individual print or online subscriptions. Visit www.surgical.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on Twitter @Surgical Clinics, and you can subscribe to the podcast through Apple, Google Play, Spotify, Stitcher, and Amazon Music. Thanks for listening.